Welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board certified neurologist and fellowship trained multiple sclerosis specialist. My mission is to engage, educate, and empower those impacted by chronic neurologic conditions to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things brain health, wellness, self-advocacy, and how to care for your loved ones who are impacted by chronic neurologic conditions. Join me and my super friends and special guests as we get ready for the next episode. And most importantly, let's get nerdy. Hi, friends. Welcome to another episode of Brain Chat. I'm Dr. Mitzi, the nerdy neurologist, and I am so excited about today's episode and the topic and the special guest that we have with us today. If you have never been on an episode of Brain Chat, type in the chat. Let us know where you are viewing us from. I'm bidding you greetings from Atlanta, GA, where we are actually in fall, which is great, and not fake fall, because we sometimes have fake fall before we have real fall. But I think we're in real fall. So sweater weather is my favorite, and it's a beautiful time in the city. So I hope that everyone's doing well. And we are going to get in this episode. And also we want to thank our sponsor, the National MS Society. All right. So we have got an action-packed episode ahead of time. And I want to talk about a subject that's really common, right? When we hear the word stroke, everyone has been impacted by stroke in some way. And there are also a lot of misconceptions about stroke. So we're going to talk about stroke. We're going to talk about TIAs. We're going to talk about all that good stuff today. And I have got an expert for you to help us in this conversation. Dr. Alexis Simpkins is the Director of Vascular Neurology Research in Neurology at Cedars-Sinai Medical Center and the Script Research Program. Through this program, she provides leadership for developing new research initiatives within the stroke division and conducts cutting-edge translational research on cardiovascular disease, aging, novel acute stroke treatment, stroke prevention, and advanced brain imaging. She has over 59 peer-reviewed publications. Now, that's a lot of dances. So everybody that knows me knows every time I do a publication, I do a dance, but I don't know if I can do 59 dances. So she is really getting that work done and publishing about it. She has funding from multiple organizations and foundations, including the National Institutes of Health. And she is the director of the CREST Initiative, which promotes the research and career development of trainees interested in cerebral vascular disorders. She's a fellow of the American Heart Association Stroke Council and a fellow of the American Academy of Neurology. She participates in leadership positions on committees and subcommittees for both of those organizations. And recently, she was awarded the American Academy of Neurology A.B. Baker Teacher Recognition Award, the American Heart Association Stroke Journal Outstanding Reviewer Award, and the UC San Diego US 10-Day Inclusive Excellent Award, as well as top scholarly contributions within the top 0.5% of scholars in cerebral vascular disease by Scholar GPS. Welcome, Dr. Simpkins. Welcome to Brain Chat.
Hi, how are you? Thank you for
I
having
am
me.
doing well. Listen, 59 is a lot of publications. So that's a whole, like I said, that's a whole lot of dances. So thank you for all of your contributions to the work and into the field, because we know that when we're doing publications, that's how we educate the community. That's how we move the science forward. So, a lot of people are doing the work, but are not publishing it. So thank you for all of those amazing contributions. And thank you for hanging out with us on Brain Chat. All right. So my first question for all of my guests is, how did you get into the field of neuroscience? Tell us your origin story, so to speak.
Okay, sure. So I always liked medicine. I loved medicine. I used to read medical books and things like that when I was little. Don't ask me why. I just really liked the way organs worked, diseases, all that kind of stuff was just kind of the thing that I like to focus on. And my mom was a director of a daycare center, so and I love kids. I thought I was going to be a pediatrician. And then I, went to Augusta College for my undergraduate. And while I was there, one of the mentors that I had suggested that I do this research program that was at Medical College of Georgia. So in
Hmm.
doing that, they connected me with some people who were doing stroke research. So I worked with Dr. Susan Fagan, who was also part of a research group with Dr. David Hess, and I found that to be so interesting. I got to see exactly how drug discovery and things like that actually takes place. And so I was like, okay, this is intriguing. And I still didn't decide on neurology or stroke until I had more clinical experience and then actually gone into medical school and realized I really liked going through the neuroanatomy and the pathways in the brain. I found that to be the most energizing aspect of the anatomy courses that we all have to take. And then when you actually go on the wards and you see what happens to patients acutely when they're having stroke and what you can do to intervene that can have a complete life changing effect for the patient, it's a pretty remarkable thing. So that's what drove me to want to go into neurology as a field, medicine first, then neurology as a field, and then to specialize in stroke and why I'm on this the pathway of doing uh, working with stroke patients, but also doing research because we have so much more room to go on improving our care for stroke patients. And so that's the reason why I do both. I love to take care of patients. I love the interactions with the patients and being able to help people to get better from their symptoms. And then
Hmm.
even with the symptoms that a person has as residual as part of the stroke, helping them to navigate that space, the patient and their family. And if we can come up with better ways of treating things, then we can reduce a lot of that, the effects of the stroke, such as not being able to get around like you want, like people would normally if they didn't have immobility or disability related to the stroke, or being able to think the way that they normally would if they didn't have the stroke. So those are really pivotal things that we still need to do a lot more on as far as coming up with better ways of treating patients from a system of healthcare aspect, reducing
Hmm.
healthcare disparities, and then making sure there's better therapies as options on the table.
Okay. Yeah, so that's amazing. So we crossed paths. I spent quite a few years in Augusta. I did my training there for residency and for fellowship, and then I stayed on as faculty for a couple years. So I definitely hear some of those names that you're saying, that got you interested in the stroke aspect of neurology. So let's just take it all the way back. What is a stroke, right? So people have many misconceptions. Like, obviously, there are some symptoms that we know are a stroke. And we'll get into some of the weeds, but what is a stroke? What is going on with the brain or with the nervous system when someone has a stroke?
So, stroke is the term stroke comes from many years ago from Hippocrates, saying that someone was afflicted with something and they were struck down out of the blue with an affliction. And so,
Mm,
struck down translated down into stroke. In general, what it means is a person has lost the ability to do a particular thing with their arms, legs, moving their mouth, vision, or any kind of neurologic function all of a sudden, and the cause is related to either brain tissue that's dying because they don't have enough blood flow, or that brain tissue is damaged and compressed because there's been a blood vessel that has burst open, or blood that is leaked into the cranium. So there's two different types. One of them is
mhm,
called ischemic stroke, and that's when there's not enough blood flow to the brain. So if you think about it, it's just like if you had a yard of grass, and if you have a sprinkler system set up, if one of the parts of the sprinkler system gets plugged up by something or a rock and you're not able to sprinkle part of the grass will die. The same sort
mhm,
of process happens in the brain, but it's a very quick process. Our neurons are very metabolically hungry, meaning they need lots of oxygen and they need lots of glucose. And that's why 20% of our cardiac output goes just to the cranium itself, just so that we can constantly be restoring glucose, which is the energy that the neurons use to function, and the oxygen in order to keep the cells alive. So if a blood vessel becomes blocked off, either the blood vessel collapsed on itself and closed, or a clot from somewhere, goes up and plugs up one of the blood vessels. Those neurons, after 30 seconds or so, are starting to not be able to function properly. And over time, they will die. And that is what we call an ischemic stroke. So, not enough blood flow going to the brain. The other
Mm-hmm.
type of stroke is called a hemorrhagic stroke. So that's a hemorrhage, meaning that the problem is because a blood vessel, because we have blood vessels that supply blood to the brain, bursts open, and then you have blood going out into the skull, either dissecting into the brain tissue or laying on top of the brain tissue, being and compressing the brain, because we, it's a cranium. We have a our skull only has but so much size there, so it doesn't, the skull doesn't expand out to make room for blood if it's bursts out into the brain tissue, so that causes a lot of damage. Most of the time when patients are having a stroke, it is the not enough blood flow type of stroke, which is
Mm-hmm.
the ischemic stroke. So that's about 80% of the cases. Then the other group, or the other 20%, is the hemorrhagic stroke. So when there's blood that bursts open into a part of the brain, or in the area that's laying on top of the brain.
Mm-hmm. So let's talk about causes. So you said ischemic. So two main types of stroke are ischemic, lack of blood flow, and hemorrhagic, too much blood going where it's not supposed to go. What are some of the common causes, let's say, of an ischemic stroke versus a hemorrhagic stroke?
So the main interesting thing is that one of the most common risk factors for stroke in general, whether it's hemorrhagic stroke or ischemic, is high blood pressure, and in
Mm,
particular, untreated high blood pressure. The
mm,
reason for that is because, again, we need the blood vessels to be healthy. They're like your highway, your conduit for the blood to travel up and go to the brain tissue so that we can get all the oxygen, glucose that we need. If the road, so to speak, is being damaged all the time by, lots of excessively high blood pressure, the body will do things to try to auto repair itself. And it doesn't do it in a way long term that is healthy. So
mm,
you'll end up with damaging remodeling in those blood vessels. So what does that mean? So you'll get damage in the lining of the blood vessel cell. The blood vessel is just like a is has multiple layers to it. The inner
mm-hmm,
layer is the signaling layer. Once that layer gets damaged, cells will come in like inflammation or inflammatory cells and try to do a repair or recovery process. Also, anything that it finds as floating through the bloodstream that it thinks it can, so to speak, spackle some of that damage up, it will use. So things like cholesterol, because the cholesterol is flows through the bloodstream, is being carried by carriers to go, to different places and through the liver. And so the damaged part of the blood vessels will attract things like cholesterol and inflammatory cells, and that's what leads to hardening of the arteries, or atherosclerosis.
mm,
And over time, that cholesterol plaque, will get bigger and bigger and can cause the blood vessel to collapse. And that can be an ischemic stroke. At the same time, sometimes that thick layer of cholesterol plaque that's there can become unstable and kind of rupture open and attract the sticky platelets that are in the bloodstream that we normally have to do patch and repair if we were to get a nick or a cut, or we need to make sure we're keeping the right balance of bleeding and clotting. But when you have damage to the blood vessel, it will attract those platelet cells, and they will stick and adhere to the damaged part of the plaque into the inflammation and lead to plaque, what we call plaque rupture. And
mm,
clot can dislodge from that plaque and go up and cause stroke. The other part, so that's the ischemic stroke. So for ischemic
mm-hmm,
stroke, a lot of the cause thing that hypertension can do is that it leads to remodeling of the blood vessel, that can cause the blood vessel to get thicker, can cause the blood vessel to have cholesterol plaque. Those cholesterol plaques can rupture and then lead to clot to go up to the brain. But at the
mm,
same time, it's just like if you had a garden hose, and if you turn the spigot up, it is full blast, eventually you're going to weaken the integrity of the garden hose. Same thing with the blood vessels. And
Mm,
the blood pressure can't, our bodies can, are only designed to maintain the stuff within a certain blood pressure range. And if the blood pressures are chronically elevated, those walls of the blood vessels will try to beef themselves up to be thicker to handle it, but eventually they get to the point where they can no longer keep
mm,
tamp down the pressure and they can rupture open. And that's what we call a hemorrhagic stroke. One of the most common forms of a stroke is a hemorrhagic stroke. There are some other more rare types of hemorrhage that can happen in the brain, such as from aneurysms. So those are little
mhm,
outings that will blister out from a blood vessel wall. Sometimes those things happen for, genetic reasons, but we definitely know that there are some things that we can do to reduce the likelihood of having things like cerebral aneurysms, and that's blood pressure control, not and definitely not smoking, particularly for
mhm,
women. And those are
mhm,
some of the main things. So hypertension is a big one. So making sure that the blood pressure
mhm,
control, even if you do have high blood pressure, that you take medications in order to keep it under control, diet, exercise, reducing the salt intake, and those things like that. Now, there are other things that can also increase risk of stroke. So I will just touch base with the most common ones because I think that that
mhm.
would provide the most
Yeah.
information. So high blood pressure is the big one. The other ones are going to be high cholesterol, again, because you got
Mm,
all that extra cholesterol floating around waiting to find some damage to stick to. So, high cholesterol. The other one is diabetes. So,
mm,
uncontrolled sugar, blood sugar is a big risk factor for stroke. And the reason for that, again, goes back to inflammation. Well, when you have lots of sugar floating around in the bloodstream, it can be very sticky and stick to the lining of the blood vessels. And our body knows that we're not supposed to have those sugar molecules attached. And so the immune cells will say, oh, that shouldn't be there. And they go in and try to clean up and remove anything that's got too much sugar attached to it. And that inflammatory response to the high glucose chronically over time leads again to damage to the blood vessels, in particular the smaller blood vessels or the capillaries. So
mm,
diabetes is a big one. And then also another one of the big ones is atrial fibrillation. So
mm.
that term I know people probably have heard on some of the commercials that are now out.
Lots of commercials.
Yeah, AFib, talking about monitors and things like that. But that condition is an irregular heart rhythm. And our heart is supposed to beat on time, supposed to always have a conductor so that the heart is pumping on time. Why is that important? Well, we need to have regular blood flow to all of the organs, but
Mhm,
also, too, if the heart, particularly the top chamber of the heart, is not squeezing and all of the myocytes are not squeezing in concert to push blood out of the heart, that means that things are not being properly evacuated, particularly from a part that's on the heart called the left atrial appendage. And when blood sits still and pulls, it clots. So if the
mhm,
fibrillation is called, it means quiver, to quiver. So instead of all of the myocytes contracting together, you've got this sort of quivering response. That means you're not pushing all the blood out. And that gives room or time for little clots to form in this area called the left atrial appendage. And those clots can be pumped, go and be pumped up to the brain. So those are some of the most common ones. So we have large vessel atherosclerosis, so plaque buildup, cholesterol plaque building up in the arteries in the neck, in the brain. The smaller blood vessels that can be damaged also is another big place that leads to stroke. So that's from the small vessel disease. It's called what we call small vessel disease, which is typically caused by high blood pressure, diabetes, smoking. Smoking is another big one for the plaque here. So smoking I bring up is because that is another modifiable risk factor that we can address to reduce risk of stroke. The when people the smoke it's smoking, the fumes and the burning in the ash is toxic to blood vessels, and again, that leads to inflammation. The inflammatory cells get activated. You end up with plaque buildup from doing things like smoking. And then the irregular heart rhythm is the one of the most common ones. There are some other more rare causes of stroke or less frequent things that I think I will mention. One that's less frequent, less frequently associated with stroke, but
Mhm. Yeah, so,
a
we
patent Freeman Valley, the short.
uh-huh. Yeah, sorry, we
So the
lost you for just a
short
second, go
term
ahead.
is,
Mhm.
oh, so a patent Freeman Valley. The short term is called a PFO.
Mhm.
And that is another risk factor for stroke, particularly more associated with stroke in younger patients who are otherwise healthy. Now, the tricky thing about a patent Freeman Valley is they're not super infrequent. 1 in 4 people has a patent Freeman Valley. They are basically the conduit that's open when the child or the fetus is in the womb. That's how nutrients get from mom to the baby while they're
Mhm.
during the gestational period. But normally, when the baby takes their first scream or really fully inhales and expands their thorax, that patent foramen ovale will close, or the PF, and then or the it will completely seal, and then you won't have that conduit. But occasionally, it doesn't completely seal, and then you'll have the conduit there. That being said, we do not know if there are other things specific to certain stroke patients who have a patent foramen ovale that increases their risk more than others, because patent foramen ovales or PFOs are super duper common. 1 in 4 people has one,
Mhm.
but 1 in 4 people
Mhm.
is not having a stroke. So
Right.
before addressing something like a patent foramen ovale, it requires a multidisciplinary team to evaluate that person to make sure that they don't have another condition that is the more likely cause of the stroke. So you'd have to rule out everything else, like the blood's not too sticky from a disorder that might be making a person clot more than they should, um, that they don't have like a heart problem or a heart valve
Mhm.
problem, or that it isn't from something like the other conditions that we talked about, which are much more frequent.
Mhm. Yeah, so such important and valuable information. And a lot of what I hear you saying is that some of the causes of stroke are modifiable, meaning they're things that we can do health wise to prevent them.
Mhm.
And then another large piece of it appears to be if we are diagnosed or if people are diagnosed with some condition, such as high blood pressure or diabetes or high cholesterol, it's important to make sure that you're checking in with your doctor, that you're getting monitored, those levels are where they're supposed to be, that you're taking that blood pressure medicine or getting it adjusted, because what is happening over time is that even if you feel okay, right, and you're not taking that blood pressure medicine, even if you feel okay in the temporary sense, those diseases, if they're
Mhm.
uncontrolled, are making changes to your body, making changes to your blood vessels that can set you up for a poor outcome. And that's, I talk a lot about my patients. When I talk about, for instance, multiple sclerosis, I make an analogy to hypertension, which people call the silent killer, right? Because in the moment, you may feel fine. Your blood pressure is through the roof. You're not taking your medicine because you feel okay, but it doesn't mean your body's not being affected. And unfortunately, by the time that stroke happens or that heart attack or whatever that bad outcome is, we can't fix that. Now, we can try to prevent something else from happening to you, but we just have to, see how your body heals. There are interventions for stroke, which we'll talk a little bit about. But once that insult happens, depending on when we get to you, we may not be able to fix that damage. And so I think that that's really important for people to recognize, is that you got to be going to see the doctor. You got to be getting checked out, because this damage to your blood vessels can be happening over time and set you up for a severe outcome from a stroke. So let's talk about symptoms of stroke, right? So there are a lot of symptoms, neurologic symptoms, that can overlap with many different diseases. So, for instance, sometimes with multiple sclerosis, I'll have patients who've gone to the hospital and initially they were getting worked up or evaluated for stroke and come to find out they didn't have a stroke, but they had MS. What are some of the common symptoms that people should be aware of, if they're concerned, or should be concerned about that are related to stroke?
Sure. So that's could be a very difficult thing for people to tease out. Is this something or is this nothing? The key
Hmm.
thing is that you were able to do everything to take care of yourself, walk, talk, move your arms, legs, see, and everything. And all of a sudden, you cannot. Your arm is not working. You can't feel it. You cannot talk. You can't control the side of your face. Half of your vision is out, or one vision in one eye is out. You're dizzy and you cannot walk straight. Some of the symptoms can be very subtle and hard to pick up. And,
Hmm.
um, that's partly why we have to go to residency to, to learn all of the neural exam, and we also get imaging and things like that to help us with making sure we get the correct diagnoses. But I
Hmm.
think that the take home point is that there's a acronym called Be Fast that can help people kind of tease out what is this that I'm doing. So the American Heart Association has this acronym, and it's called Be Fast. B for balance, E is for eyes or vision, F is for face, so facial weakness, A is for arms or arm or legs that not working. S is for speech, like a person couldn't, can't talk. And T is for time. Because like I was telling you, the neurons are super metabolically active. Our brains are constantly firing off, and that's what allows us to do all the elaborate things that we do. So the brain really needs the glucose and the oxygen. It's very sensitive to not having glucose and oxygen. So as soon as stroke signs or symptoms show up, it's important to call 911. It's not to say, oh, well, maybe my arm's not moving. Maybe, if I sleep on it, maybe I should just wait. I can't walk. I'm dragging my leg and my hand's not working. Maybe, I can shake it off. No, that's a 911 call and get to the hospital. And from there, because if you arrive quickly enough, we are able to try to activate our stroke emergent systems. Every hospital calls them something different: code
Hmm.
brain, brain attack, code stroke, call it what you may. But that's when we are able to try to intervene, because once the symptoms have gone on too long, if the tissue has died, we do not have ways of regenerating neuronal uh, neurons in a way that is like FDA approved to help with stroke patients. But
Yeah.
we do have ways of trying to prevent exacerbation and expansion of stroke. And if you get there soon enough, we might be able to reverse the aspect of things. But the key is to get to the hospital if you're having stroke signs or symptoms. And Be
Yeah.
Fast is a good acronym to use.
Yeah. And so I think that's so important because oftentimes people will just blow off symptoms, right? So it is not normal for you not to be able to move your arm. It is not normal for you not to be able to feel your arm no matter how you slept. And so I think some of it is just making sure that we are paying attention to our bodies. And if something is not right, it does not hurt to get checked out, right? It may actually save a part of your brain. And so I think that that's, really important to underscore. And thank you for saying that. So when someone goes to the hospital and they have a stroke, what kind of tests are done to determine if you've had a stroke or if you haven't?
So the first thing that usually will happen, especially let's say that you notice your symptoms right away and you're able to get to the hospital as soon as possible. Usually, and this is another thing that I will say, because sometimes people will try to walk in. That's not the thing to do. You want to call 911 and get an ambulance to come and pick you up. So why? Because when the ambulance comes to pick you up, they will be able to check your vitals. If you need a line, if you need IV, They can start a line, they can start an IV. If the airway is not protected because of the stroke, they can protect the airway. They will notify the hospital that you are on the way. And physicians like myself will be alerted and say, okay, we're going to be in the emergency room to be there when they arrive. Because again,
Mm,
time is brain. If you come
right.
in and you're like, I'll just put, he can't move or can't move his arm or leg, I'll put him in the car and drive him there. You can do that, but then you're going to sit in the waiting room and you're going to wait for someone from triage to recognize that you're having stroke signs or symptoms, and you're just delaying everything. If you call EMS, they're going to turn on the lights and sirens. So everyone's going to get out of the way, all the cars. You'll get to the hospital. There will be a trauma bay waiting for you open. You're not going to have to wait. The physicians who are stroke responders will know about you and be ready to respond as soon as you arrive. And
Mm-hmm.
also, not only with the stroke physicians, the neurologists, but depending on the hospital, sometimes the interventionalists or the physicians who would need to maybe do an emergency procedure could be notified. The CT
Mm-hmm.
techs who are going to scan you, the do the imaging of your brain will be notified, the nursing will be notified before you arrive. So it's really important to call 911. Now, let's say once you come in through the door, they push you into the emergency room. First thing we're going to do is get a sign off from the EMS provider that came to pick you up. We'll get your meds. We'll go through what happened. You're immediately going to be pushed to, depending on the hospital, you will be pushed to some form of imaging as long as your vitals are stable. That could be a CT scanner. Most of the time it's a CT scanner, but it also could be an MRI depending on what's going on and what institution you're at. But some form of brain imaging so that we can uh, confirm whether you have the blood vessel burst type of stroke, or is this a not a blood vessel burst, but this could potentially be an ischemic type of stroke, because those have
Mm-hmm.
completely different forms of management, and you can't
Mm-hmm.
figure that out without getting scanned. Once you're scanned, and we can decide if this person needs a procedure because there's blood in the brain, or this possibly could be a stroke and we need to give emergency medicines. And that could be a clot buster. There's two types that are currently most frequently being used. One is called tenecteplase and the other one is called alteplase, or tissue plasminogen activator. Those are
Mm-hmm.
clot busters that can be given through an IV to try to help break down a clot in patients who've been screened by the neurologist to make sure that the risk is as low as we can possibly make it for bleeding complications. And then immediately after that, we use, depending on the situation, we usually also obtain imaging of the blood vessels from here up to the top of the brain so that we can see if there's a major blood vessel blockage that could be pulled out quickly with a stent retrieval device in order to restore blood flow. Because our goal is to try to, if the blood is not going to the brain because there's a blockage there, remove that blockage. If there's blood that's expanded within inside of the brain, then we need to do an evaluation to decide what the next best form of management is, based off what the cause of the stroke might be, or cause of the hemorrhage, and go from there depending on what's going on. But imaging is very important to obtain. There are things called mobile stroke units. So you may have a situation where a maybe EMS comes and picks you up from your home and takes you to the
Mm-hmm.
closest mobile stroke unit that has a CT scanner actually in this sort of a bus like ambulance, so that they can scan the brain and go ahead and start initiating therapy if you are a little bit further out from the hospital. So there's lots of different approaches to this. The main thing is to make sure that you call EMS 911, because all of those systems for emergency activation get activated right away once the EMS comes and sees that you have stroke signs and symptoms. And they also can triage you to figure out which hospital you need to go to based off of what
Mm-hmm.
they see, so that makes sure you get to the right hospital. You wouldn't want to go and drive to local hospital X, but they don't actually have the person on call to take care of your problem. You're still going to have to be transferred to the other hospital, but EMS will know where to take you.
Mm-hmm. And I think, again, so many, nuggets that you said there. Time is brain, right? A stroke is an emergency, and we have a window during which it's best for us to intervene with treatment if that person is appropriate for treatment. I think the other thing that's really important about using the emergency route to go to the hospital is that there are some hospitals that don't have a neurologist on duty, and they use a telemedicine system where a neurologist will come on the screen and evaluate them. And again, to make sure that the neurologist on call who's sitting at home is aware, to make sure that the screens are all set up so we don't have any problems, to make sure there's a nurse to examine you and be that go between. It just gives us a little bit of extra time and warning so that everyone is prepared and ready to make sure that we treat you appropriately. I actually remember there's several systems that are used, but there's one called the Reach system. And I actually remember, I'm dating myself here, when I did my interview for residency at the medical college, they had just rolled out the Reach system, and so it has really changed the way that stroke is treated, because now people who are in rural communities can potentially get, brain and function saving treatments in places where there wasn't full neurology coverage. So, again, that time is of the essence. If that leg is not moving and you get out of bed to go pee and you crawling, do not get back in that bed and go to sleep. Please call 911. Please don't
Yes,
get back in that bed and go to sleep and hope that it's better when you get up.
right.
Because if you get there, we're able to do more than we could do, 10 or 15 years ago. And the treatments have really advanced. So now let's talk about, it's a whole lot of stuff that people come in and tell me that wasn't a stroke, right? So let's talk about what's not a stroke. Let's talk
Mm-hmm.
about these mini strokes. Let's talk about TIAs, right? Let's talk about what is an actual TIA and what is not an actual TIA. So a TIA is basically a warning symptom of stroke for our audience, and you can explain it in further detail, Dr. Simpkins. But I get so many people that come in, they say, Doc, I fell out 30 times and they told me it was a TIA. And I was like, well, honey, if it's happened 30 times and you wake up normal, that is not a TIA. A TIA is a warning, and usually you get one, maybe two warnings, and you're going to have a big problem that's not going away. So let's talk about what is an actual TIA or warning symptom of stroke and what is not a TIA, and then we'll go on to mini strokes. So let's focus on the TIA first, and then we'll come back to mini strokes.
Sure. So, well, they're kind of people interchange the terms of mini stroke and TIA.
Mm-hmm.
If you go by like the clinical diagnoses, a TIA would be or transient ischemic attack is a person who has neurologic deficits that last less than 24 hours. Now, and that's kind of sort of also segued into this term of like, well, I had a mini stroke, or like that it wasn't a full one, it was a little mini one. But the key thing here is usually now the brain is a really wonderful and mystical thing, and that people can have all kinds of stroke signs and symptoms. But in general, stroke symptoms localize to vascular territories because you're dealing with blockages of blood flow related to either an ischemic stroke. It's very rare to have a TIA from a space occupying hemorrhage. So we
Mm-hmm.
don't tend to talk about the TI, like the mini stroke type realm. That's not necessarily per se so much for hemorrhage type stuff in general. There are some rare circumstance, very, very, very rare, like we're talking about few percent type thing of,
Mm-hmm.
genetic disorders that can lead to people who have, transient neurologic symptoms that come and go. But we're talking about the mass bulk of the diagnoses that people will come in with. Hemorrhages usually cause space occupying neurologic deficits that persist because the blood does not takes time for blood to disappear. So transient ischemic attacks are really talking about transient periods of ischemia, transient periods of blockage of a blood vessel that feeds a particular turf or territory of the brain. And
Mm-hmm.
that vascular bed controls specific parts of the brain and leads to patterns of stroke syndromes. We know if you block this particular part of this vascular bed, it causes this symptom. If you block this particular patch of brain tissue or from a vascular bed, it causes this type of stroke syndrome. So in
Mm-hmm.
general, if it is a TIA, we would expect the symptoms to be less than 24 hours, and it should fit the pattern should fit a vascular territory that would be suggestive of a cerebral vascular problem.
Mm-hmm.
In general, because we're talking about resiliency of neurons, if you've had 30 of them, people have come and said, like, I've had 15, if you don't have a stroke on your MRI, is not likely, that does, and your brain scan is completely clean. There's no signs of prior stroke. By the time you've had multiple episodes, like you're saying, the neurons aren't that resilient to be able to undergo that lack of blood flow over and over and over again and not show
Mm-hmm.
patterns of damage. So in
Mm-hmm.
general, we would expect, if you've had multiple episodes, that you're going to see some areas of damage that are going to be involved, even if the symptoms were transient. Now,
Mm-hmm.
there are some syndromes where people can have things called limb shaking TIAs or things like that.
Mm-hmm.
That's when someone maybe has a carotid artery that's really blocked, or you can have, symptoms from that, or you can have stuttering symptoms, fluctuations of stroke signs and symptoms when someone is having a stroke, depending on
Mm-hmm.
how much blood perfusion dependent someone's brain is, you know, but in general, TIAs are transient episodes. They don't happen over and 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 over again. In general, they usually will
In
happen
general. Mm-hmm.
um, like once or twice. And even for those episodes, you need to come to the hospital, because that suggests that something is happening, that maybe that carotid is 99% blocked and you need an intervention like ASAP. And
Mm-hmm.
if it happens, maybe we can get to it before you actually go
You
on
had
to
a
have a
stroke.
stroke. But it's not
Mm-hmm.
typical that you'll have, uh, you know, over and over and over and over and over and over again, and your brain scans completely clean, because the neurons just aren't resilient for having tons and tons of ischemic incidents back and back to back to back. There are lots of
Mm-hmm.
what we call stroke mimics that can do that.
Mm-hmm.
Lots of stroke
Mm-hmm.
mimics that can do that, like migraines. Um,
Mm-hmm.
I mean, there's a lot of things that can do that, but they're not
Right.
typically. If it doesn't fit a vascular pattern, it's probably not a cerebral vascular problem. And if you're having recurrent things, but always coming back completely to normal and no signs of brain damage or on the brain, a scan is, it's time to start thinking. Um,
About something else.
yeah, it would mean that, like, okay,
Mm-hmm.
let's at least evolve our differential to make sure we're not missing something, because if you're having them over and over and over and over again, that means you've missed, something's missing. We need to figure out
Right.
what this is.
Exactly. Exactly. So important. All right. Believe it or not, this has gone by so fast. So I got two quick questions I want to ask. Brain Chat is very much about people advocating for themselves, and learning what they can do to prevent or live with chronic neurologic conditions. So, I've heard many things that you've said. We talked about some of those diseases that can damage the blood vessels, which lead to stroke. So, it's important for people to control their blood pressure, monitor that with their primary care doctor, their cholesterol, diabetes, etc. I would say now, you got to go to the doctor to get checked out. Now, I've had some folks who have come to the hospital with a stroke and said, I didn't have any medical problems. And I said, well, when's the last time you've been to the doctor? Like 10 years ago. And I'm like, well, you had them, you just didn't know, right? So it's important for us to be getting those checkups. What are other things that people can do to prevent strokes?
So, a great tool that the American Heart Association has, I think, is called either Life's Essential 8 or Life Simple 8. It might be Life Simple 8. It's a
Mm-hmm.
website that has these 8 pillars of things that it is based off of the population in the United States, things that are modifiable that can be addressed to reduce risk of cardiovascular events and stroke. And it gives you a tool to kind of modify your risk profile yourself and to track it yourself and go over this information with your primary care. So it allows you to be better able to advocate for yourself because it will list out all of the things related to your diet, your blood pressure, your cholesterol. This is all
Mhm.
information that you can be getting from your primary care and can help you to have a dialogue with them on what's really important that should be addressed to help reduce your risk. So that's one thing that I recommend for patients to use as a tool to help them to advocate because sometimes, I mean, it can be difficult to know, okay, well, I'm going to the physician. Aren't they supposed to tell me what I'm supposed
Right.
to be
Right.
doing? But this is true, and it's very true. But it's always good to be able to advocate for yourself because
100%.
sometimes you might be that, okay, well, maybe this isn't the right fit for me because I see my life essential A or my life simple A is telling me that I need to address this. This blood pressure isn't the right goal for me. And
Mhm.
if this person isn't gelling well enough with me to understand my goals, maybe I got to find a better fit because
I love it.
that can sometimes be the thing that you need to do in order to advocate for yourself. And it's not necessarily just giving you information on what to talk about, just specifically with your primary care about the medicines they give you, but also the lifestyle things that we are all in control of for ourselves, such as what we
Mm.
eat, how we manage our stress, how we are sleeping, how we're cultivating our social networks. All of those things are also super duper important. A lot of the things that contribute to stroke risk, and we talked about like these episodic events, but the
Mhm.
other thing that I would want to emphasize to people is that, there's the acute stroke that happens, like we talked about, but the long term span of chronic disease can also lead to cognitive problems over time and
Mm.
lead to vascular dementias. So even if
Mhm.
you're not feeling it and maybe you've never had a stroke, you don't want to get to, age 60 and you're not able to cognitively do the things that you want to do because that decreases your quality of life. So stroke is a lifespan disease. It is about taking care of ourselves during childhood, taking care of ourselves while we're young adults and into adulthood so that we can prevent not only the slow burn sort of process that leads to the vascular cognitive impairment, but also
Mhm.
episodes of stroke where we really have like these massive losses of neuronal function. We don't want either of them. So
Mhm.
life simple aid or life's essential aid through the American Heart Association is something that I would advocate for everyone to look at for primary prevention. My
Mhm.
goal is to making sure that you don't have to see me on the teledoc video conference
Absolutely.
or see me in
Absolutely.
the ER.
Absolutely. So well said. And last question, what are you excited about in the field of stroke?
There's so much. There's so much.
Give
I
me
think
your top 3, top
my
2 or 3.
my top three is I'm really excited about all of the health equity research that's being pushed by multiple societies and the
Mhm.
NIH to help us to get better on our goals for stroke care, not only just by race and ethnic groups and social determinants of health, but also gender, sex. Make sure
Mhm.
men and women and everyone, all people from all backgrounds are being treated equally. And then I'm really excited about some of the preclinical research that's being conducted that's pushing some new novel therapies through the pipeline. And I'm excited about the youth of the future. It's important to make sure
Mm.
that we are continuing to pull people from behind that are going to be continuing to feed the pipeline and push the envelope further to help us to continue the momentum.
Absolutely. And so much to be excited about. Thank you so much, Dr. Simpkins, for your expertise, for just making it plain. There's so many nuggets and so much valuable information that you have given the Brain Chat audience today. So I thank you for taking the time with us. And I thank you to all of our friends who are viewing this and who will get so much out of this information. And of course, thank you to the National Med Society for sponsoring us. All right, Brain Chat friends, we will see you again in 2 weeks. Have a great one, everybody.